So thanks for having me. It's quite exciting for me to be able to speak to you about this. So I'll just give you a little snapshot of who I am, and so you have some sense of how I've worked with young people in the past. So my name is Dr. Lawrence Deck, and I've been a registered psychologist for over 12 years now. And I've worked a lot with young people in the mental health realm, in the correctional realm, working at a youth treatment center for almost a decade, and then working in the forensic system in a correctional center for young people for several years. And so this is something that's kind of near to my heart. So what we're going to try and do is try and talk through some of the common mental health concerns that impact our young people, and what we might be able to do about that. So on this first slide, what we're doing is we'll delve through some of the most common types of mental health concerns that we see, and that would be ADHD, oppositional defiant disorder, and conduct disorder, and what we can actually do to help our kids, some of the medications that are often used, and how we assess for these things. I'm going to slide in a little something else about trauma, because I think that it's very important to talk about, because it kind of can mask all these other diagnoses. So on the next slide here, we're just going to start to get into ADHD and talking about how frequent it is. So what we know is that ADHD is one of the most prevalent childhood psychiatric disorders in Canada, with boys being about 3 times more likely to develop it than girls. And it might be because their behaviors are more externalized, and so we're more likely to label these things and that they're more problematic. So typically we see this arising, starting to see it present itself around 3 years old, 3 to 5 years old, and we're always going to have ADHD diagnoses that are before 12 years of age. And 75% of the cases of ADHD will continue throughout adolescence. So the diagnostic criteria are basically threefold. So one, predominantly inattentive type, predominantly hyperactive or impulsive type, and then we have a combination. On the next slide, we'll see that the breakdown for each. So we're talking about a persistent pattern of inattention or hyperactivity that interferes with functioning and development. So symptoms prior to age 12, as I said, and symptoms are present in more than one setting. So if somebody is kind of disruptive just at home, if they are kind of jumping all over the place and they seem to have a lot of energy, but it's only at home, that would not be considered. We want to see that kind of behavior at home, at school, in the community, that kind of thing. So there is clear evidence that it's reducing the quality of their social, academic, interpersonal functioning. So just because somebody has a high level of energy, but it's not getting in the way of maybe their schoolwork, it's not getting in the way of how they're developing relationships, we wouldn't consider that for the diagnosis, because when we're diagnosing somebody, we want whatever the symptoms are to be interfering with their functioning. Okay? And then obviously it's not better explained by some other mental health diagnosis. Sorry, on the next slide here, what we see is the predominantly inattentive type. This is people often failing to pay close attention to details. Maybe they have difficulty sustaining their attention. They don't seem to be listening when people are speaking to them. They have difficulty with organization. They avoid or dislike tasks that are kind of monotonous or require sustained attention. They lose things a lot, sort of like my kids. They lose their gloves every other day. I should have stock in that. They're often distracted by extraneous stimuli, and they forget things that they likely shouldn't be forgetting. On the next slide, we see the predominantly hyperactive or impulsive type. So this person fidgets or squirms a lot. In class, they might leave their seat frequently. They run, they climb, they're flying all over the place. They're always on the go. They excessively talk. They blurt things out in class. The teacher might ask, hey, can you please raise your hand? And they just blurt things out. They have difficulty waiting their turn, and they interrupt. So this is the most the most difficult one. This is the one that people see the most often because it creates the most problems within school or within the community. On the next slide, obviously, we kind of talk about both, so they could be inattentive and hyperactive, which are going to have this profile where they're not paying attention and they're all over the place. So some signs of hyperactivity and impulsivity is feeling restless, fidgety, hands and feet are moving, so they have trouble sitting still, they're always moving, running, climbing, leaving their seats, blurting out things, having difficulty waiting in line, so they're always butting or pushing ahead. Then on the next slide we see signs of inattention. This is becoming easily distracted, even by irrelevant sights and sounds. So they're sitting in class and they hear a noise in the hallway and their attention goes there, and then it takes some time to come back. Often failing to pay attention. So this might be they take a test and they do poorly on the test, and then as a parent you go home and you say, but you know how to do this, we've done this together, and you realize that they just made a whole bunch of really careless errors, rarely following instructions or completely losing or forgetting things like toys, pencils, needing to do something. So they might have a set of chores that they do all the time and they just are forgetting to do these things frequently. Often skipping from one thing to another, so they jump around quite a bit. On the next slide, we see what this looks like in our kids. So children and adolescents with untreated ADHD are at greater risk for learning difficulties, less academic success. We see earlier school dropout and fewer years of schooling. Additionally, we see mental health disorders and problems with self-esteem. We also have a higher prevalence of substance abuse or becoming involved with the criminal justice system. So more accidents and more sustained injuries as well. And this includes when they get a little bit older and they're driving vehicles because they're not really thinking things through very much. Next slide, we just look at kind of how this progresses, the etiology. So there is a high genetic heritability. We also see some neurobiology, so parental stress, low birth weight, severe early depression, traumatic brain injuries can also impact maternal smoking and pregnancy. We believe that there's some association with the dopamine and serotonin system, and some decreases in volume in the frontal and temporal lobes. And also there are some thoughts that this might be connected with diet. So next we look at kind of what some of the treatment recommendations are. And I am going to preface, we could do a whole hour just talking about ADHD. We could do a whole seminar just talking about ADHD. So I'm just trying to give you the high level information so that you can just kind of have a general sense of what this might look like in your kids. So I do realize that I am going through this quite quickly. Ultimately, the goal of treatment is to reduce or eliminate the ADHD symptomology. And so we want to do this because we're trying to improve academic or occupational functioning, and we want to improve social skills. Those are the main two goals. So we see that treatment options might be multifaceted. So we can have medication alone, we can have behavioral intervention alone, or we can have a combination of the two. Okay? So ultimately, I think the best approach is a combination of the two, particularly if the behavioral intervention doesn't work. So usually what I recommend to parents is we start with a behavioral intervention. We see, are there things that we can do that might modify the environment or modify the way that people are approaching this young person, skills that we can teach the young person that will help them in order to make them more effective. If that doesn't work, then I often suggest starting to get some medication involved. We're talking to their physician to see whether that would be an ideal fit for them. So I always like the intervention of behavioral and environmental in combination with medication alone, or in combination with medication. So there are consequences for people who are not treated for ADHD. People with ADHD, they can tell that things are not going well, right? They often have these challenges interpersonally, they have challenges academically, they might have challenges at home, or people are often frustrated with them. And so when this happens over and over and over again, we see kind of an unraveling of their sense of self, right? Having academic failure, not doing as well as you want, seeing that your peer group is making bigger strides than you, that can have a serious impact and does impact academic failure. So we want to make sure that we're trying to put intervention in place to help these young people so that they can feel good about themselves. Because the consequence is getting involved in antisocial behavior, the consequence is seeking a peer group where their expectations are lower. And so that often leads to criminal behavior. So we want to help people to feel better about themselves, and we do this by helping them improve from a behavioral standpoint, potentially using medication to augment. But the ultimate goal is so that they feel more comfortable that they can manage the things in their life. So on the next slide, you'll see this word multimodal. And really what we're talking about is trying to use interventions rather than just one intervention, and when that doesn't work, we just throw our hands up and say, well, that's, things are not going the way we want them to. Well, we want to use a multimodal. So we want to use a bunch of interventions aimed at different things. So parent training, behavioral intervention strategies, appropriate educational programs, education regarding ADHD, individual and family counseling, and medication when required. So when we put all of these things in place, we provide an opportunity for, if one thing doesn't work, that the other things will be more successful. On the next slides, I talk just basic about some general needs. So a good premise is general health will help with mental health. So if we think, how can I help my young person to be healthier, we're going to put them in a position to have better mental health. So what does this mean? This means regular exercise, right? There's a lot of good information out there about aerobic activity and the impact aerobic activity has on the brain functioning. Dr. Rattay has a book called Spark, The Revolutionary Science of Exercise in the Brain. And in this book, he talks about how effective exercise can be in regulating young person's brain functioning and learning by increasing the amount of BDNF, brain-derived neurotrophic factor, in their brain, by adjusting the amount of serotonin and dopamine in one's brain. So exercise can be really, really useful way to help to regulate somebody that has ADHD. Healthy diet. So cutting down sugars, increasing the amount of water, adding more omega-3 fatty acids to your diet, right? So there's lots of people out there that are very, very knowledgeable about diet and nutrition that can potentially help a young person who is struggling with ADHD. Getting plenty of sleep, right? Regular sleep can vastly improve symptoms of ADHD. Simple changes to daytime habits go a long way. We can try therapy, right? Having people be able to talk and gain experience and some strategies about how to manage their symptoms can help improve somebody's self-esteem. So we help young people to learn new skills. We help them to cope with the things that are going on from them. Maybe help them to manage stress and anger, control impulsive behaviors, and then helping to maintain a positive attitude. So again, we talk about how there's this intermatch between general health and mental health, and the more we focus on general health, the better outcomes we'll likely see for our young people with ADHD. So on the next slide, I'm not going to talk a lot about this, but there are lots of different medications that can be useful for young people with ADHD. We have stimulants, or long-acting and short-acting, and we have non-stimulants. Medications are really created to help young people to better regulate, and some of them work really effectively, and some of them don't work as effectively. There's lots of different options now, and so your general practitioner or family doctor or a child psychiatrist can help you to find the best medication for your child. Unfortunately, like with almost any medication, there are adverse side effects, and so again, I'm not going to dig into this too deeply, but some of the more common ones would be loss of appetite. Sometimes it can impact sleep, can create a bit of upset stomach. Sometimes it decreases appetite actually. So some have some appetite suppressant. So for growing kids, that may not be the greatest thing. It can sometimes impact mood, and because lots of them are stimulants, they can sometimes create some psychomotor agitation. Again, your doctors can help you to figure out what might be the best option for you as you go forward, if that's a road that you're looking to go down. So I'm going to transition here to oppositional defiant disorder. So oppositional defiant disorder and conduct disorder are similar but different. So when we think about the two, we're kind of thinking about severity. So we'll start with oppositional defiant disorder. So how we would define it is an enduring pattern of uncooperativeness, defiance, hostile behavior towards authority figures that does not involve major antisocial violations. So this is anger, irritability, mood, vindictiveness, and again, sort of like ADHD, we'll see this in multiple settings. So not just in the home. So in my home, my son doesn't follow the rules, he doesn't listen to what I'm saying, and then I go to parent-teacher interviews and I say, how's he doing? And they say he's lovely, he follows the rules, he listens, he's a real gentleman. And I say, well, why don't I see that at home? Well, we wouldn't consider that would not meet criteria for oppositional defiant disorder because we're only seeing it in one setting. So we would want to see this in multiple settings. On the next slide, this just kind of breaks down what we might see. So this is a person that often loses their temper, lots of arguing with adults, they defy or refuse adult requests, they're deliberately doing things to annoy people, they blame others, they're touchy, easily annoyed, often angry or resentful, and often spiteful or vindictive. Slide, we kind of look at what conduct disorder would look like. So this is a repeated and persistent pattern of behavior in which the basic rights of others are violated. So that we see lots of social norm violations. So aggression to people and animals, destruction of property, deceitfulness, theft, serious rule violations. So we can see that in oppositional defiant disorder, there might be this arguing, this balking at tasks, this kind of refusal to kind of engage. But with conduct disorder, we're seeing that, but we see all these rule violations. So we're thinking more, they're starting to break the law, they're indifferent to the rights of other people. People are much more impacted by their behavior. Serious rule violations. So with conduct disorder, we see kind of two different subsets. One, we see this behavior starting before 10 years old, and the other, which is the adolescent onset, we see after 10 years old. So we can also code this by mild, moderate, or severe. So typically what we see is that when we have this diagnosis before age of 10, it's much more serious. It's more challenging to move through. Now, I'm going to preface one thing here, that most young people show some sort of antisocial behavior in their life. So the research is very, very clear on this, that we see an upward pattern in antisocial behavior and criminal behavior starting to rise up 15 years old, peaks around 21 years old, and then it comes back down. So this pattern is we can pull it up anywhere online, and we can see that in general, people are a little bit more impulsive. They try and fit in with their peer group. They do things that get themselves into trouble, and in general, it goes up. And we shouldn't be super, super worried about that pattern because it's going to come back down. However, what this is, the way that this is different is that pattern is starting earlier. And so when we see an earlier pattern, often we have a little bit more concern. And when the behaviors become serious violations, we have more concern. So typical behavior where young people, maybe they steal something, or they shoplift one time, or they early age drinking or whatever it is. Those aren't the kind of behaviors that would meet criteria for this. We're talking about serious violations, stealing cars, hurting people, hurting animals, repeatedly stealing over and over and over and over and over again. This is the kind of behavior that might get us to start thinking about this being a conduct disorder type problem. Saying the conduct type behavior is bullying, threatening, intimidating, physical fights, weapons, things that could cause serious harm to people, cruelty to people or animals, stealing, robbery is a bigger one, deliberate fire setting, destroying other people's property, often lying, running away, staying out all night, not going to school. So we're looking at a more increased behavioral output. On the next slide, we'll see epidemiology for this is, 5 to 8% diagnosis for conduct disorder, whereas oppositional defiant disorder we're looking at, around 10%. And then the ratio is much different from boys to girls. Girls is about, 1 in 10, where, the ratio from boys to girls is 10 to 1. So boys are 10 times more likely than girls to be diagnosed with conduct disorder. And then there are some gender differences in the way that the symptoms are expressed. And as we talked about before, we see this developmental pathway, the early onset versus the late onset. So conduct disorder and oppositional defiant disorder is associated with the person's environment. So we see higher prevalency of this when there's poverty or disorganized neighborhood, violence within the home or neighborhood, abuse, neglect, inadequate supervision, poor quality of schools. All of these things contribute to this behavioral output. And so what we see is that there are ways to control or mitigate this. So if we're changing those variables, then that might improve somebody's outcome. I just kind of highlight some misconception that he'll grow out of it. This is not always the case. Sometimes is, particularly if the onset is later. So when we see this adolescent onset, sometimes that will help them to grow out of it. But we also have to remember that something likely has to change, whether that's environmental, the way that we're managing or parenting. But it can, like conduct disorder, can lead to antisocial personality disorder. And a lot of those people get into a significant trouble and cause significant harm to others. So the notion that, well, if we just give them time, they'll grow out of it, that might not always be true. So early intervention is the most effective. So if we're starting to see this behavioral output, we want to put in place things that might mitigate the harm that people could cause or cause to themselves. And really, medications here, when we're talking about medications, is not a medication for ODD or conduct disorder. Usually what happens is they get medicated for the behavioral output. So lots of these people may be diagnosed with ADHD at the same time. And so what they're trying to do is treat the impulse, right? We treat the impulse, and then we think, well, if we treat the impulse, then the person is less likely to get into trouble. And so they're trying to treat one of the symptoms versus treating ODD. So on the next slide, I just we talk about the developmental progression of conduct problems and behaviors. And so you'll see this kind of oppositional, offensive, and delinquent, and how the progression happens from preschool through adolescence. And you can see in this that things are progressively getting worse. And so we want to intervene early. So when there's just oppositionality, when there's arguing and bragging and impulsive and temper tantrums and stuff like that, that's when we want to be intervening, because it's easier to intervene then versus when it's starting to shift into cruelty and lots of fights and that kind of thing. And what we have to remember is that when those things are happening, likely there's other types of interventions that are getting involved, likely the legal system. And this exacerbates the problem because now we have a young person who's going to be further down that path because they're going to have contact with more people that are in trouble. They're going to learn new skills. They're going to have a lower sense of self and kind of feel like the system is against them. So we really, if nothing else, getting anything else from this slide, it's that I want you to see that early intervention is likely the best thing for these young people. And so I just talked briefly about some etiology of conduct disorder, and we see that there's some family and twin studies out there, and shared environment obviously has an impact. Exposure to tetragens, in vitro, abnormal neurophysiological responses. And so this is where I'm going to start to delve into another component, which is trauma. in just a moment, because I think trauma will do a good job of explaining a lot of why we see and how people may be getting misdiagnosed. So on the next slide here, you'll see some associations between conduct disorder and ODD. And so we see intelligence and underachievement in school are connected, lack of emotional intelligence, so people not really being switched on to what's going on emotionally for them. There's some personality factors, so impulsivity, some callousness, being a bit unemotional. There's problems in relationships, and that includes peer relationships, family relationships, relationships with authority figures, with teachers, that kind of thing. And often there's some co-occurrence of other mental health disorders at the same time. So this could be ADHD, anxiety, depression, or substance use. And whenever we have a dual diagnosis, so whenever there's multiple diagnoses at play, treatment is always more challenging. So just treating ADHD is going to be simpler than treating ADHD with a substance abuse disorder or ADHD with anxiety issues. So we have to hit this from multiple heads. Working with parents is a big thing. So the way that parents respond to their kids is going to have a significant impact on the way that their children behave. Problem-solving training, family therapy, preventing issues. So trying to hit things before they happen, being very proactive in our approach. Lots of times kids come into my office with their families and they're having behavioral problems, and the thought is, well, just fix them. Right? We see this in residential treatment as well. The family comes in, and if the kid just behaves better, then everything will be good at home. And really that's not the approach we want to take. We want everybody to be working together because it's not just a kid problem, it's a family problem. On this slide here, we see parent behavior training. So we want to be working with parents. As I said, the way that parents respond is going to have a big impact. And we want to help parents so that they're not overreacting and they're not personalizing the things that are happening in their home. So a young person does something and the parent says, well, you're disrespecting me, right? Or you're making it seem like I'm not a good parent. And so they get angry and elevated. And so we want to help parents to step away from that. We want to help them to be responding versus reacting. We want to help them to decrease their verbal output a bit, right? So we want to act, we don't want to talk so much. We want them to be more consistent. So a big problem that we see with kids who have ADHD or oppositional defiant disorder or conduct disorder is that there's a lot of inconsistency in the way that parents are interacting with them. So what often happens is parents will have a plan. There'll be a behavior that they're trying to manage. They'll have a plan and they'll start to put that plan into action. And at some point, they'll get tired. They'll have a long day at work. Something will happen and they'll throw that plan out, or they won't do that plan. And so what this does is it reinforces to the kid, well, if I just keep rolling, at some point they'll cave. And so consistency is so important because anytime we're inconsistent, we're sending a message and we're reinforcing that I can break this person down, or I can kind of continue to angle up the ante until I get my needs met. And so consistency is really, really important. And we also want to only put things into place that we can actually do. So if I have a behavior that I'm trying to modify and I say, well, I'm going to do this and I'm going to you're grounded for a month. Well, I actually can't control that. So if my young person goes to school and they don't come home because they choose not to, well, I can't actually control whether they came home or not. And so them being grounded, those words don't really mean anything. So when I put an intervention in place, it has to be something that I can actually do, right? So I could actually take the cell phone, or maybe I can't take the cell phone because my young person is bigger than me. I can actually deactivate the cell phone. That's something that's in my control. I can't control whether they get another one or if they pay for it themselves, but I only want to put in place intervention that I can control. And what we often see is that parents do things that are out of their control or that they can't control frequently enough, and then we see problems. So really working to respond, not overreact, decrease personalization, talk less, let our actions do the speaking, and be more consistent is a big, big thing that is going to help parents to help to manage their children. So I'm just sliding through my slide here as I was putting it. I had big mistakes for parents, inconsistency, and then I tapped forward, inconsistency, tap forward, inconsistency. So I was really trying to highlight, and you'll see on my slide that I'm really trying to highlight that inconsistency is one of the things that derails parents the most. And I can say, even honestly, as a psychologist, in my own home, when I think about the times that I've had difficulty, it's because I've been inconsistent, right? So I have a set of expectations, and then for some reason I deviate from those expectations, and then I'm upset because things didn't go the way I wanted them to go. So on the next slide here, we see oppositional defiant disorder. In short, disruptive and defiant behavior. These behaviors have a payoff. So they're doing them for a reason. Maybe it's about attention or a reaction. Maybe it's about getting them to have a removal of demands. Maybe they're testing limits. Behavior has a purpose. And when parents and adults can understand that behaviors have a purpose, then they can have some ability to respond rather than react. So when you're dealing with challenging things from your young people, I want you to think, what are they trying to get out of this? What is my son or daughter, what is my student, what are they trying to achieve here? Okay, so I'll give you an example. So a young person in a class, they're disruptive. They keep disrupting class, and I can ask myself, well, what are they trying to achieve? So do they need attention? Are they needing more support with their academics? Are they trying to do something so they can get kicked out of class because they don't want to be there, maybe because of learning challenges? Are they upset with me about something that I've said or done and they don't know how to properly talk about that or articulate that? Are they just trying to see how far they can go before like the intervention of the line gets crossed? But if we think about behaviors as them trying to tell us something, then that can be a real useful way for us to respond to things that are going on versus reacting. So behavior is telling us something. So there's some parent training for young people with ODD, so differential attention. So really what this is we are attending to average or positive behavior as much as we can. Every time I see something good or decent or average, I'm attending to that. Hey, thanks for taking care of that. Oh, I noticed that you did that. Hey, thanks for not making a mess. Da 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 da. I'm always reinforcing those things. I'm really, really giving praise for exceptional behavior. Anything that's over the top, I'm really, really praising those things. Things that are positive but maybe average, I'm also noticing those things. And these things that I don't want to exist, I pay less attention to those things. I don't react to those things in the same way. I respond. And so sometimes we can do this also with our language. So we can tell people what we want them to do versus what we don't want them to do. So a lot of the time with parenting and in classes, we're saying, don't do that. Don't do that. No, you can't have that. Don't do it that way. And another approach is actually to say what we would like them to do. So if somebody's having an emotional outburst, I could say, I'd prefer if you just told me what was bothering you. Or next time, can you do it this way? So we're actually trying to teach people what to do rather than try and push away what not to do. Some on the next slide here, you'll see some tips, some do's and don'ts. So this is in regards to ODD. So some do's and don'ts. Do, describe. Describe what you're looking for. Reflect, right? Take a moment, take a step back from the frustration or the irritation of what's happened and reflect back to the young person what's happening or how you're seeing it. Imitate. So you can show people what to do. Praise, right? Touch. And when I say touch, what I mean is connect emotionally before you go to the logical. So there's some information out there that kind of suggests that when somebody's heightened and they're emotional, their logical processing systems are probably not working all that effectively, right? So if we think of the hand, and this is not mine, sorry, I'm stealing this from another very smart individual. We're talking about this idea of young people flipping up, and so this is the frontal cortex here, and this is the limbic system. And so what happens is when a young person or an adult gets activated, their cognitive reasoning goes offline, their executive functioning goes offline. The emotional center is stronger. This is the fight or flight or free center. And so when that takes over, this goes offline and we're not thinking as clearly. So if we have an activated young person, going to this place of logic is not always the most effective thing to do. We first want to go to the emotional side, and we want to settle the emotional side. And then once we settle the emotional side, then the logical side will come online. And when that happens, then we can have the logical conversation about what they can do next time or whatever. But sometimes we need to touch them emotionally before we can go to this logical side. I hope that makes sense. And some don'ts. Don't command, don't reprimand, and don't necessarily question. These things are with somebody who's oppositional, are going to lead to immediate pushback. So on the next slide, some basic things that are useful for ODD. Keep it simple. Be direct. One step at a time. Start small. And do commands versus like, if you don't do this, right? And that's what I mean by commands. If you don't do this, then, like we're kind of making a threat. And when somebody threatens us, what happens? Our emotional center kicks in. Oh, I'm in danger. And the logical center goes off. But do commands are helpful, right? Might be helpful to do it this way. We're telling them what to do versus what not to do. Language is so important when we're communicating with kids, whether that's kids that have ADHD or ODD, have some conduct-related behaviors. They're so important, the words that we use and how we're using them strategically. So, for the last half an hour or so, I've been giving you a high-level overview of ADHD, oppositional defiant disorder, and conduct disorder. And the reason I'm giving you these is because these are the most common things that we see diagnosed in our youth. So I'm going to transition. I'm going to shift to something that I think should be a major consideration, something that we should really be thinking about when we're seeing any of these behavioral profiles, whether that's ADHD, ODD, or CD, conduct disorder. And that is trauma. Okay? So trauma or exposure to trauma can mimic or seem to be showing us the same symptoms that we would see in these three disorders. So it can have a profound impact on young people. So it can impact their sensory development. It can impact their sense of safety, kind of shattering that. It can impact their ability to accurately label dangers, heighten their level of activation, alter their interpretation of things that are happening. It can impact their cognitive functioning, including their memory, attention, perceptual awareness, thinking, language skills. And depending on when this trauma exposure or multiple exposures happens, it can have a significant impact on development. And what we know is that when this happens when somebody's quite young, it can change the way that the brain develops. It can change all their physiological, the way that their nervous system is kind of reacting to stimuli that's around them. And so when we know, or when we find out information that maybe trauma is involved here, it might be, kind of an important thing to explore before we just jump to this person has ADHD, or this person has conduct disorder, or this person has oppositional defiant disorder. Trauma often underlies much of what we see in mental health. So trauma can look like a lot of different things. So this next slide, the trauma exposure slide, is just a brief snapshot. This is, there could be many more on this, but this could be a young person being exposed to natural disasters, war, terrorism, exposures to domestic violence within the home, They could be a victim of physical, emotional, sexual abuse, or even neglect. So this can take lots and lots of different forms. This could be even them witnessing violence at school over and over again. So if you are thinking about your kids, or thinking about your students, ask, where did they come from? Did they come from a region that was war-torn? Were they in a refugee camp? What was the relationship like between their parents? Were their parents really working to make things better for their lives? And so were they working a lot? And so maybe there was some inadvertent neglect. Maybe parents are just trying to survive. And because of that, they're having to do lots of different things, and they're not as present, right? All of these things can factor into trauma. And so it's important, before we just jump to ADHD and oppositional and conduct, that we actually think about this other factor. The diagnostic criteria for PTSD are this. One, they have an exposure, a significant trauma exposure. Usually this is life-threatening, okay? Or that they believe that their life was in danger. Or maybe they're witnessing that same profile. They're witnessing significant situations where other people are injured, hurt, that kind of thing. They're re-experiencing. So they're having thoughts, memories, dreams, nightmares, or dissociative reactions, right? So things are popping up for them, and they continue to think about these situations that are happening. And so there's difference between a thought or a memory about a situation and a dissociation, where the dissociation is they kind of are leaving where they are now mentally, and they are right back in that traumatic experience. So both can be present, or one can be present. Also, avoidance. Avoidance is very common. So this can be a lot of different things. So if I'm trying to avoid a thought or a memory, I might engage in behaviors that will help me to do that. So I might be engaging in dangerous behaviors so that I'm not thinking about it. I might be trying to keep myself really busy. Maybe there's something that's triggering at school. There's a boy that looks like the person that hurt me, or a teacher that looks like the person that hurt me, and so I'm going to try to avoid that. So I'm going to act out behaviorally so I get kicked out of school so that I don't have to see that person. Maybe I'm starting to use drugs or alcohol because I'm trying to avoid those thoughts and memories. So avoidance can take lots of different forms. So again, when I talked earlier that behaviors tell us a message, maybe the message is I'm trying to avoid something that's traumatic or triggering for me. Hyperarousal. So this is our nervous system is firing. So we are aware of everything that's going on around us. So I'm going to be maybe more jumpy, right? Maybe I'm going to be seeming like I'm all over the place. It looks like ADHD. It looks like hyperactivity, but maybe it's just this hyper-aroused nervous system as a result of trauma. Negative alterations in cognition and mood. So maybe they have difficulty with recall, distorted cognitions, changes in their emotional state. And maybe this looks like emotional volatility, and it looks like their inabilities to recall, looks like they can't remember and they're not paying attention. Well, yeah, they might not be paying attention because they're focused on this horrible thing that may have happened to them, or this horrible thing that they witnessed. Alterations in arousal and reactivity is the next diagnostic criteria. So the person looks like they are irritable and they're angry. Well, yeah, maybe they're that way because of this traumatic situation that happened for them. So that's a change. They didn't always used to be that way, but because of this traumatic thing that happened, it's changing the way that their nervous system is working. It's changing the way that they're regulating their emotions. And the other diagnostic criteria is that we would see this profile for more than a month. This happens very frequently, and depending on where your young people are coming from and the things that they were exposed to in their lives, we could see this present itself quite frequently. So, there's a study that shows that 15 to 43% of girls and 14 to 43% of boys have been through at least one trauma, and of those, 3 to 15% of girls and 1 to 6% of boys develop PTSD. So this is pretty high rates, and the rates are different depending on the type of the trauma. So some traumas create more of a problem than others. This is from the U.S. Department of Veterans Affairs, this statistic. So I only say this in that not all of the young people that are coming through your door that look like they're oppositional or look like they're antisocial or conduct or look like they're ADHD are. There may be a large number of these young people that have a significant trauma exposure. People who are exposed to trauma, and that could be one traumatic event, so a rape, or they were badly assaulted, or they witnessed somebody that was badly assaulted or murdered. So it could be one incident, or it could be cumulative in that they saw lots of small things, right? Or maybe they heard lots of things, right? So they were in a war-torn country and they heard lots of bombs going off. And although, and every time they heard a bomb, maybe they feared for their life, or they knew that other people were dying. So this profile it could be one trauma or multiple traumas. So what you might see is a young person having difficulties focusing on learning. Again, if I'm worried or activated about my safety, learning about mathematics might not be all that important. You might see a development of learning disabilities. You might see poor social skill development. You might see these people act out in social situations. You might see them behave violently or aggressively, right? So some social learning here. They've seen this, their defense mechanisms going up. I showed you the hand before, right? So this is the logical part, this is the emotional part. If the emotional part's taking over, and this is saying, keep me safe, keep me safe, keep me safe, fight, fight, or freeze, you know, they might have learned that I need to fight in order to survive. And so anything that activates them automatically activates that response, and maybe we see this aggressive behavior from them. Maybe that's physical, maybe that's verbal. We might see young people who can't trust, have trouble making friends, that they are regularly blaming others for things that are going on in their life. They might lack self-confidence. They might have poor emotional regulation, and they might have some physical symptoms. GI issues, stomach, headaches, right? These are all things that you might see in this profile. And some of these things look like other mental health disorders, but they're trauma. So if we are identifying that we have a young person that might be impacted by trauma, there are lots of great and effective treatments for this, okay? So again, I love the multimodal. I love multiple different approaches to treating somebody. Right? So we can have behavioral interventions, we can have interventions where parents are more educated and aware about what's happening, but there are really some really great specific treatments for trauma. So cognitive behavioral therapy is kind of, you know, something that we can use for most types of mental health disorders. We also have CPT, okay, so cognitive processing therapy. This is a specific therapy for trauma. Again, it's more cognitive based. We have EMDR, so eye movement desensitization and reprocessing. This is more of a combination of a top-down and bottom-up approach. So it's a therapy which is really nice. I really like it for young people because there's less talking involved. They don't have to come to these like aha moments where they're changing the way that they're thinking necessarily. Whereas the process naturally helps them to kind of heal, and by means of doing that, by healing their nervous system and their feelings in relation to these things and helping them through some negative cognitions, they feel better and they feel safer. There's ART, accelerated resolution therapy, and prolonged exposure is another. So these are all trauma-specific trauma treatment modalities that are specific for treating trauma. And some are better for young people than others. And some are better depending on whether the young person's level of cognitive functioning, how they process information, how many incidents they were involved in. So the therapist that you work with can help you to figure out what might be the best treatment course. But if we have young people that have trauma, we should be treating the underlying problem. So sometimes what we see is that the person has trauma and they have maybe inattentive problems or they're impulsive, and so we start treating the impulse control issue. Well, until we address the underlying problem, which is the trauma, we're likely going to still continue to see that behavioral output. So we want to try and get to the root. And so I encourage people to be super curious about their young people and the young person's history before they jump to some of these other diagnoses. So kind of think trauma first. And if we can rule trauma out, then we can go in and think about, okay, how are we going to address these behavioral issues? But think trauma first. And we can help people by getting an accurate assessment. So on this slide, I'm just kind of brief overview of what we would look for during the assessment process. So one, we should have psychometric evaluation. So there's lots of great tools out there that will help us to identify legitimate psychopathology. And we want our practitioner, whoever that is, to be using the best gold standard tools to identify whatever it is we're looking for. And assessments would also include interview with the clients, interview with the parents. We want to make sure we get really, really rich collateral information. There might be additional information that's needed from the school, right? Because remember, we're looking for multiple settings. How does behavior present itself in multiple settings? So we want to have a lot of rich information. And then any collateral documentation is really great. So if they've seen a different practitioner, maybe they saw a different mental health provider, maybe their general practitioner, their family doctor can provide information about that. And I also think a developmental questionnaire is really, really useful so that we're seeing how things may have been throughout the developmental trajectory, as well as getting any information potentially about trauma. So what happens is we take all of that information, all those different data sources, we put them together, and hopefully that gives the person doing the evaluation information to put down, to be able to create a comprehensive treatment plan for the young person, create an accurate diagnosis for the young person. And there's lots of great tools out there, and I've listed a couple here under here. There's, for ADHD, we have the SNAP-26, the DCEFs, the BASC. Again, I don't think this is all that important. Your provider's likely going to, whoever's doing the evaluation should be able to select appropriate measures. But really, we want this combination of information from psychometrics to interview, collateral sources, and we want the data sources to kind of fit and merge so we can say, yeah, this is the data's telling this, the parents are telling us this, the school's telling us this, and everything fits together. And when it doesn't fit together nicely, then we have to ask, okay, what are we missing here? Or why are we only seeing this behavioral output at this place and not another? What's the variable that's causing the dysfunction in that place? And once we understand that, then we can put together a treatment plan that's going to address the young person's needs. Please be aware of trauma because it can mask or mimic some of these other disorders. I've given you a brief overview of ADHD, oppositional defiant disorder, conduct disorder, and what you might be able to do in order to help with those particular things. Often we want an approach that involves something to do with the parents, right? Parents making some sort of adjustments, young people, helping young people to gain skills or to gain insights into what's happening for them, and potentially medication management. And that should always be done in conjunction with your family doctor or your psychiatrist. But not just one approach. Wrap everything together so that we're providing a plan for young people that's going to help them to feel successful, and with the ultimate goal of increasing their level of self-esteem so that they have a better picture of themselves. Because often young people who don't feel good about themselves are the young people that get into the most trouble. So hopefully that was helpful. Again, I know we flew through the information. It's only intended to be an overview, and hopefully we can augment this with more learning coming forward.